David's got us wired in, so no matter where you're at, you'll hear me. I can, maybe once we start. Let's do it.
All right, we'll get started.
I think I'm glad it's not a beautiful, bright, sunny day, or we'd maybe have 2 people in here.
Although we are in a mall, we'll be fine going shopping for sure.
That's true.
Hi guys, I'm Katie. I'm on the board. I'm here to introduce these 2 lovely ladies. I'm sure most of you, including myself, have an OT and a PT in your life, or will have in your life at some point. This is Nancy and Kelsey. Nancy is an OT, a registered OT, and she is in a rehab clinic. She's a rehab clinical specialist at Children's Minnesota. Her primary area of focus is in improving the developmental outcomes and quality of life for patients and families with congenital heart disease. She attended the program in occupational therapy at the University of Minnesota and has been with Children's Minnesota for over 27 years. She has provided pediatric occupational therapy services in the inpatient and outpatient settings for a wide variety of patient populations during her career and holds certifications as a lactation consultant and a neonatal touch and massage therapist. She enjoys spending time with her husband and 2 children, doing anything outdoors, fun.
I'd be one of those
camping,
outdoors.
and cross country. And then Kelsey is a physical therapist, and also she works at Children's Minnesota Rehabilitation Clinic in gait and support. And gait and supports Children Gait Clinic program as well as Children's Serial Casting program. In 2022, Kelsey co-founded Children's Physical Therapy Intensive Universal Exercise Unit program. She's been a physical therapist with children since 2018 and graduated with her doctorate in physical therapy from St. Catherine's University in 2013. Kelsey is passionate about helping children move in the best possible ways during their childhood and helping kids invest in their ability to continue to move throughout their adult years. Evidence-based research helps Kelsey and her team make decisions around how to best assess a child's walking and what kind of physical therapy treatments may be most effective in helping a child and family reach their movement goals. Outside of work, Kelsey spends time outdoors with her family, going camping, hiking, and lots of other things.
Awesome.
Thank you.
Thank you. Again, I'm Nancy, and we're both from Children's Minnesota, and I just really appreciate being invited to come and speak today. We just got the whole intro. Should we just skip that bad boy? We have nothing to disclose. So these are our objectives for today. We're going to start by just really reviewing the concepts of developmental delay and how to support children through all stages. We're going to discuss what OT, PT, speech, and feeding therapist roles are, and really talk about the importance of early intervention. We're going to introduce some of the specialty areas of rehab service and other activities that can support your kids with developmental challenges. Finally, we're going to talk about how parents and other caregivers can take an active role in their child's life. Oh, sorry. Too many there. There we go.
There you go. So a term that a lot of you already likely know and have heard from medical providers or maybe while even doing your own research is developmental delay. Developmental delay is when a child is not meeting their milestones at the time that we would expect them to. These developmental challenges can impact one area or multiple areas, and they can impact areas such as fine motor skills, so being able to grasp, gross motor movements, including sitting, crawling, walking, cognitive or thinking skills, social and emotional skills, how your child may interact with others and how they regulate their emotional skills and feelings. Behavior and speech and language skills are also domains where we can see delayed development. We know that childhood experiences affect how a person functions or navigates their world in adolescence and adulthood. The way a child functions and their ability to interact with others during their developmental years influences their quality of life, and impacts their developmental systems. If we, as rehabilitation therapists, can intervene in childhood and help kids move through new experiences by teaching them skills that they may be delayed in, not only will we have an impact on their current quality of life, but also their lives in the future. There is an abundance of published research, as well as guidelines from the World Health Organization that suggest that early intervention in areas that are delayed have a positive effect on both the child and the family's overall function and quality of life. A child's brain is going through rapid growth and development during childhood. Our brain and nervous system have a significant role in how we learn and how we develop skills and movement. Neuroplasticity is a term where neuro means related to the brain and plasticity means change. Our brains are meant to learn and change, and a child's brain is especially primed for change and for forming new brain connections based on new and repeated experiences. Children with Mowat-Wilson may have differences in their brain structures. For example, some kids with Mowat-Wilson have hypoplasia or agenesis of the corpus callosum, which is that big bundle of nerve fibers that connect both sides of the brain. The guiding principles of neuroplasticity help to explain how we can spark change in all brains, even in those whose brain may be structured in an alternative way, and especially in developing brains. The first principle of neuroplasticity is use it or lose it. If you aren't exercising your brain in a specific skill, then that skill may not be as easy to access. However, we can use it and improve it. So training and practice will help to progress a skill or a movement. The more that you use your brain in a specific skill, the better you will get at that skill. Specificity matters. So what that means is that we need to practice that specific skill that we want to get better at. Practice must be repeated. We have to practice over and over again. And not only does practice need to be repeated, but that practice must be intense, and it has to be done often, and it must be challenging enough in order to make a change. If it's too easy, then we're not going to make a change in the brain. Salience is important. Salience means that the task or practice has to be meaningful to the person. So for our kids, we often motivate them with play and social interaction during therapy in order to make the practice more meaningful to them. Age also matters. The younger the brain, the more capable the brain is of adapting and creating new pathways. So the earlier we can strengthen and teach brain pathways through practice, then the better outcomes we see. Other principles listed here are interference, transference, and time. Interference is when a skill has already been learned one way, and then it can be a little bit more difficult to overcome and learn that skill in a different way. Transference is generalization of that skill, so transferring that skill from one environment to the other. And then timing matters, especially after a recent change, like an injury or a surgery. So when we think about building new developmental skills, how we practice, how hard we practice, and how often we practice are all important considerations. Practice makes permanent. What we practice is what we learn. One of our goals as rehabilitation therapists is to help you as the caregiver and your child how to perform a skill that is going to help your child with their development. For OT, this may be brushing teeth or getting socks on so that your child can be more independent with dressing. For speech, maybe your child is learning how to use an AAC device. Or for PT, maybe we are working on taking steps without help. We assess your child's current abilities and help you identify meaningful and attainable goals to work on in therapy. The goals that we choose to work on depend on where your child currently is in their development, where they are at in their medical journey. Do they have planned procedures upcoming, or do they have a recent procedure that may have set them back? And then how much progress do we think that they can make based on their current skills and the support that they have and our assessment? Also, we need to remember that salience matters, so the goals that we are choosing to work on in therapy, we have to make them meaningful to the child and to the family. So as I mentioned earlier, repetition matters. and practice must be repeated in order to solidify learning. So we want to teach you how to repeat what we practice in therapy so that you can do it at home using your own home setup. We try to think of ways that you can integrate what you learn from clinic into your daily routine at home so that you can get those high number of repetitions in. As a therapist, I need to make sure that what I'm doing in clinic with your child can be repeated at home easily and often. Therapists also encourage health and wellness behaviors so that what your child does now during childhood development can help them to flourish as an adult. We may do this by teaching you a home program that helps support the goal areas for your child. And we may also encourage participation in community programs for adaptive and inclusive recreation or activities. Again, what your child does now is going to affect them in the future, and we want to give them as many opportunities to be included and to interact with others. We're all very social beings, and being social is a large part of childhood development. I've worked with many nonverbal children who are incredibly social, even though they're not able to use their words to express themselves. Adaptive and inclusive activity participation allows your child to use many of the different skills that they've been working on in therapies and to get a similar experience as their peers.
Okay. Well, I'm going to talk just a little bit about the occupational therapy role. So defining what occupational therapy is can be quite challenging, even for someone who's been in the field for almost 3 decades. Occupational therapy can generally be defined as the therapeutic use of everyday life occupations to enhance or enable participation. Clear as mud. Basically, occupations refer to the everyday activities that occupy our time and bring purpose and meaning to our lives. They include things that people need to do, want to do, and are expected to do. There's a lot of different occupations that have different meaning at different times of life. For example, activities of daily living for someone like me would include taking a shower, getting myself dressed in a timely manner so that I can make it to this presentation on time. If we talk about something like instrumental activities of daily living, that includes things like taking care of our children or pets, financial management, shopping, driving, figuring out where the parking ramp is that I can still make it here without having to go through the rain on my way out tonight. Other occupations include things like work and play or having the social skills to participate in group activities. I cannot tell you how many times over the years people have asked me why their child needs occupational therapy when they're not old enough to get a job. For a child, occupations consist of activities like eating, sleeping, toileting, learning, socializing, and arguably one of the most important occupations of childhood, play. Play is the foundation for so much development. It is a primary childhood occupation that fosters social interaction, gross and fine motor skill development, language, cognition, self-regulation. And one of my heroes, Mr. Rogers, once said that play is often talked about as if it were a relief from serious learning. But for children, play is serious learning. Full disclosure, given that the prevalence of Moat-Wilson is estimated at about 1 in 60,000, Kelsey and I, while being extraordinary rehab specialists, have really had limited opportunities to work with children with this syndrome. So in order to prepare for our conference, we reached out to other therapists who've worked with these kiddos, got to spend some time talking with a grandma of a young man with Moat-Wilson, and then we read as much as we possibly could, scanning through the research and things like that to really try to present something meaningful today. And so what I'm going to try to talk about is based on what could be the makeup for your child and your family, but knowing that every single child is different, everybody's abilities are different, and everybody's path and journey through life is going to be different. The thing about occupational therapy and other rehab is that we don't treat a diagnosis. We specifically focus on the deficits that make it challenging to participate for OT in those meaningful occupations. For children with Mowat-Wilson, there are clinical features that vary, again, in frequency, with every child being unique. If, for example, a child has craniofacial anomalies coupled with GI issues, they might struggle with oral feeding and swallowing. If a child has cardiovascular deficits, that can lead to poor activity tolerance and possibly the need for surgery during infancy. Hospitalization during infancy can really negatively impact early milestone achievement. Children with low muscle tone can have difficulties transitioning in and out of different body positions that cause lack of stability in their core, which makes it then very difficult to learn how to use our hands and fingers in a skilled way. Some of the skeletal manifestations that affect a child's hands, such as with our pictures here, can really make it difficult to do things like put on your shirt or feed yourself with a fork, which we talked about as being a huge milestone earlier. For many children, occupational therapy is often recommended for difficulty with those fine motor skills. And fine motor skills really refer to the precision, finger dexterity, coordination of the hands, but other areas of fine motor development include pinch and grip strength, finger isolation, and they all play a role in refined use of the fingers and the hands. Fine motor skill advancement occurs in a developmental progression. And what that means is that each new skill that a child is learning builds on skills that were developed previously. So one thing to note is that the time frame on these slides are designed from a website called Pathways, which is amazing as far as ideas for developmental play and things like that, but the time frames are geared towards typically developing children. And we still need to think about, for kids with developmental challenges, development happens kind of along a continuum where that one skill is built on the skill that came before, and so on and so forth. We know that starting even in utero, foundational movement skills are practiced as the developing infant moves their hands and their arms against the resistance of the uterine wall. Newborns move their hands and arms in a general and a reflexive way while they're learning about their bodies and the environment. And then in the first few months of life, babies will start to open and close their hands and bring them to their mouth. Once those foundational skills are mastered, then they can begin to progress to grasp a toy and move it from one hand to the other and carry it to their mouth. Skills continue to build on previous skills, and babies then learn how to start picking up small objects with more of a refined grasp pattern. The occupation for the babies in this picture are feeding, self-feeding, and play. And you'll notice that the baby on the right, your right, is able to do these fine motor skills while they're just kneeling, right? And that takes a lot of core and postural stability. And so for a child who maybe has low muscle tone, OT might still be working on those grasp and pinch skills, doing some play activities, but we would maybe have them in a seating system that supports that core so that they can have more freedom of movement out here to continue to learn those skills. As children develop from toddlers into preschoolers and then to school age, they typically have had major milestone achievement with their gross motor skills. Previous fine motor skill development, coupled with the gross motor skill development, can allow for even more and more complex skills to emerge. When children struggle with neurodevelopmental delays, they lag behind in these skills that the other children are mastering for successful participation in things like school and taking care of their daily needs. From an OT perspective, if a child is having difficulties in things like finger painting, using a scissors, we need to find out why they're having difficulty. And then we work on that during our treatment session. We might do an activity with Play-Doh or placing pegs to work on things like grip strength or finger dexterity. If an older child with hypotonia and maybe poor visual motor skills is struggling to play with their friends, play ball, we might do something goofy like having them on their tummy on a swing while they're trying to pick up a weighted ball and put it into a basket. All of those things, targeting the reason they're having trouble, doing the things that are important to them. Visual motor integration is a real complex skill, which encompasses many underlying skills, such as visual perception, motor control, and eye-hand coordination. Simply stated, it refers to the ability to translate a visual image or a visual plan into an accurate motor action. Visual motor skill development begins at birth and continues to be refined throughout the life by practicing and exposure to developmentally appropriate activities. And things that we would do in OT would support things like building with blocks, scribbling and making a picture, things like that. For kids with Mowat-Wilson, visual deficits, we read, are very common. One of the things the literature talks about is strabismus, which is the picture on the top. And that's a condition where our eyes don't look in the same direction at the same time. And I think I read it's present in about half of individuals. Other things like I can never say that word, astigmatism and myopia are also common findings. And then there's something called nystagmus. And that's where there's an involuntary movement of the eye where it can kind of move rapidly from side to side. Sometimes it can be up and down, and sometimes it can even be in circles. What the research shows is that it's more common in infancies and tends to resolve over time. So how many in here have infants? Okay. How about toddlers? Preschool? Okay, and then older kids. Oh my gosh, what a great variety. That's awesome, awesome. Well, when our eyes don't work right, it makes it really challenging to develop the skills needed to do the things that we want to do, like play. So again, OTs, we would try to work on visual motor skills through just a variety of games and toys to help improve that feeds into their eye-hand coordination. All right. Oh, that's me.
That's you still.
I've got a different view on here so I can see my upcoming slide, and I keep thinking it's Kelsey's turn. But the final thing about what might happen with OT is that we know that these kids tend to have a really happy demeanor, but they can also struggle with things like attention deficit disorder, anxiety, and sensory processing issues. Some things like repetitive behaviors or oral sensory seeking are pretty commonly seen, where kids want to chew on things, chew, or grind their teeth, or chew on their clothing, or even their own body to get that big need for that oral sensory experience. There are some occupational therapists that really specialize in what's called sensory integration therapy. It's designed to help children with problems that we just kind of described. Some kids have that sensory seeking, where they crave that sensory information for their brain. Some kids crave movement, and those kids Like my son, who is now an adult and somehow functioning in the world, spinning, running, jumping, climbing. Other kids have a lot of trouble with sensory stuff. And so for somebody who's very sensitive, the sound of the fan would be the only thing that they could focus on in a room like this. Whereas you and I, hopefully most of us, have a brain that just says, oh, that's not relevant, I don't need to pay attention to it. My son with ADHD would have a hard time listening because his brain would want to pay attention to that. And so sensory integration uses things that really help those kids to either meet those sensory seeking needs or help them tolerate a very sensory rich environment like a busy school lunchroom. SI therapy can help to make transitions less disturbing and then also reinforce positive behaviors. Yeah?
Can I just ask a question about sensory? So we have an OT within our school.
Yep.
And they do sensory diets and things like that. At what point would you go to a sensory OT specialist?
I think I would say, how's it working? Is it meeting the needs? Do you have a son or a daughter?
A son is 4.5.
Okay, so is it meeting the needs to help my son function in that environment so that he is getting everything that he can out of those opportunities for socialization and learning? If it's things that are problematic at home, you know, I can't stand my socks, and so I'm constantly taking my shoes off and going out in the snow. Or I have so much sensory issues in my mouth that I can't eat a regular diet. Then those would be times that you'd want to maybe seek out more private or outpatient services. Great question.
So I love being a pediatric PT. I get to be silly, I get to laugh, I get to make up games, and I get to play with kids while I'm at work. And like as we were talking earlier too, just like following them throughout like their childhood is really fun. Like you get to celebrate with them, you get to celebrate with the families, and you are like one of their biggest cheerleaders. So it's really, really fun to be a pediatric PT. My goal is to have my kids do different therapy exercises and activities with me that are going to help them move more independently and more efficiently so that they can keep up as much as they can at home, at school, and in their community. I want my patients to get all of the benefits of movement that their typically developing peers get, and movement might just look a little different for them, and that's okay. I want to just get them moving as much as I can. So PTs enhance childhood development through purposeful positioning, problem-solving mobility options, and teaching patients and families how to use adaptive equipment. Some kids are best able to access their environment through the use of adaptive equipment. Kids can use adaptive equipment either full-time or part-time, and that could be equipment like a gait trainer, or it could be equipment like a walker, or a wheelchair rather. Pediatric PTs are experts in muscles, movement, and gross motor skill development. We have your child work their muscles in specific ways so that they can strengthen their bodies to move or to change positions. And we also work on coordination and control of that movement. Children with Moat-Wilson have a lifelong condition that will affect them throughout their lifespan. Pediatric physical therapy can help to limit effects of the lifelong conditions and to help improve the skills that your child needs to participate in their day-to-day kid stuff. PTs use purposeful exercises during play to help your child gain strength, stability, balance, and coordination that they need to explore, that they need to use in order to explore their environment. Not only can we work on improving gross motor skills, but we can help improve safety with movement and teach kids how to use adaptive equipment. We want to help your child keep up with their siblings or their peers in whatever way that is most accessible for them, and so that they can move around how they want to move around and have the same opportunities in their childhood development. physical therapy we might focus on a wide variety of areas. There's a lot of different things that we can help with and that your child may need. Children with Mowat-Wilson have differences in their muscle tone that affect how they move. If your child has low muscle tone, we may want to work on strengthening. And if they have high muscle tone, we might want to work on both strengthening and stretching. We may also see children with Mowat-Wilson who have skeletal differences such as scoliosis, flat feet, or have chest wall differences. And some of those are things that would benefit from PT to help them reduce the effects of those differences and to help them move better. Kids with Mowat-Wilson may also have medical surgeries or procedures which may affect their strength and mobility. So it's important for them to see physical therapists so that we can help them regain any lost skills or to build strength to prepare for a planned procedure. And we know that up to 52% of people with Mowat-Wilson may have congenital heart disease, and that can really affect energy levels and endurance. So as physical therapists, we may teach energy conservation techniques, work with your child on use of adaptive equipment, or design a conditioning program to improve your child's ability to be active without getting as tired. Early and often movement and mobility can be incredibly valuable to a child's overall development and milestone progress. How mobile a child is and their ability to access their environment through movement can help or hinder their development. Mobility impacts brain development, so we need to encourage early mobility. And mobility it can look different for every kid. It can be crawling, it can be using a wheelchair, it can be being pushed in a stroller. It can be supported upright walking, or it can be independent walking. Mobility activates brain pathways and helps with vision development, body awareness, problem solving, sensory development, coordination, and memory. Kids learn about the world and interact with their environment through movement. So like I mentioned, any way that they can get from A to B is mobility. And we want to make sure that we are working with your child and with you to help your child move the way that they want to move and the way that they are capable of moving. We know that the age that kids with Mowat-Wilson tend to walk at averages between 3 and 4 years of age, but it can range from 2 all the way up to 8 years. And then there are some children who aren't able to walk independently. So as a physical therapist, I think about how early can I help kids start to move? How do we help kids become more mobile if it's challenging for them and they can't do it by themselves? And then how do we help them move in a way that is accessible and meaningful to them? So there are several different options of ways of adaptive equipment to help get your child moving. And you may be familiar with some of these. So an adaptive stroller can help the child be more upright so that they can visually interact with their environment while they're being pushed. Wheelchairs may allow for more independent choices so that the child can choose where and when to move if they can propel themselves. And then there's also a couple other alternative early mobility devices that tend to be for younger children, usually like 3 or under, and can help a child explore their environment more independently. I am not affiliated with and am not endorsing, but wanted to share a couple of those examples. And I'm not sure if anybody has heard of Bella's Bumbas or like Go Baby Go. Has anybody heard of either of those? No? Okay. So Bella's Bumbas is, it's a bumbo chair on wheels. So it's for really little. So like if you're not sure if your child is gonna need like a wheelchair, but they wanna move, like it could be an option for them to try to move around. The Go Baby Go's are modified ride-on cars, and you can set different positioning so that the child is fully supported, and then they can maneuver those. So there's a couple really cool alternative movement ways.
Kelsey, we have a question.
Oh yeah.
Do you ever see regression with use
That's a good question. I have not. I think, like, I always kind of work in both ways of practice, like, you know, making sure we're doing really purposeful stepping, standing, walking, if that's the goal, like we're working on that. And if the child has already like mastered their wheeled mobility, then I'm not working on that in therapy, and we're spending a lot more time working towards that skill that they need me to help them with, which is that standing, stepping, walking. And then yeah, I don't really see that they prefer, because they get excited too when they like are standing, because it's different. And so they tend to be more motivated to do that too, in addition to. But yeah, that's a good question and good thought. Yeah, so if you like Google these, they'll pop up and you can see what they look like. We can also use a walker or gait trainer to help a child be more mobile if they're showing interest in stepping. And there are a variety of gait trainers. Some have less support, some have more support, and we just choose according to where the child is starting at. And then we will take away support or add support depending on what they need. Sometimes a child doesn't need to use that walker for very long. Like, I've had families who have like got a walker through insurance, and then the next week they're like, we don't even need it. And then there are some kids who are more safe and more independent with use of a walker. And I'm okay with that if it's allowing them to keep up with peers in the way that they need to be. And that doesn't mean that we don't stop working on independent walking if that's a goal. It just means that it's a way that they can do it themselves. Standing frames are another tool that we often use. There are a lot of benefits to the use of standing frames for a person who is not independently standing. And even for some of my kids who who are standing and are walking, but they really are heavily relying on a walker and they have a wheelchair that they're using part-time, even a standing frame in that instance can be really helpful, because we're working on stretching out the muscles that they're not using, and we're maintaining bone density. And it just lets them be in a different position other than sitting or them being flexed. I thought you were jumping the gun again. Yeah. Typically developing children start pulling to stand around 8 to 9 months of age. So for a child who has developmental delay, we can get them standing with a standing frame as soon as 9 to 12 months of age. Then if we're getting them standing when their peers are standing, then they're getting that same experience that their peers are getting. And as I mentioned, improve bone density, muscle activation, and joint stabilization are benefits, stretching any tight muscles, helping with heart health, just improving the space in the trunk to allow those organs to function better. A lot of GI benefits, so improving motility, digestion, decreasing constipation, and then it's really putting them at that peer level and allowing them to interact with peers. So I have some kids who use their standing frame at school, and they'll stand while they're learning. Or there's some different standing frames too that have wheels so you can propel yourself. So I had a kiddo who had one of those, which was really neat because then they could be upright like their peer and then move themselves.
I have maybe a dumb question, but my son's school has the old wooden standers. They look so uncomfortable. Have you ever stood in one? Are they uncomfortable?
I have not stood in one.
Every time I
She will now.
Oh.
Yeah, actually, I was
It looks so terrible, but he doesn't seem to mind it.
yeah.
But I've never
I
seen one.
I think it depends on the kid, and I'm not sure. I always kind of ask you, is your child able to express if they're uncomfortable? Do they have different behaviors that they do, or can they tell you that they're in pain? And as a therapist, I watch it really closely. If they're squirming or distressed, then it's nope, too big of a stretch. We are going to back off on how high you are in your standing frame. But most kids, when we get them custom standing frames, love it. They love to stand at home. But I would talk to your therapist that's using it. I would imagine that they would make it as comfortable as they can for your kiddo, like knowing that
If
it's
it's not customized, it's just like the school provided one, are they
Mhm.
pretty, like, you
Sim-
could make it so it fits that child, right?
yes, it's adjustable.
Adjustable.
Yeah, it's adjustable. Yeah, maybe custom wasn't the right word. It's more adjustable. Like you have more options for sizing and different like padding that you can do if you get one like for home use. But they should have all that same options in school to make it safe and to make it beneficial. Yeah, but yeah, good question.
I think when we were talking through this too, one of the things that we came across in the research is that kids with Moet Wilson will have often a very high pain threshold and don't always express discomfort and pain. And so if there were any concerns, the thing that I would want to make sure is that I talk to the school therapist and ask them to be looking at their skin when they're coming out. So your child may feel just fine and not have the awareness that maybe there's a pressure point, but they would see that through like a red spot that doesn't go away within about 20 to 30 minutes.
You could also see if they'd be willing to send you a video of them in the standing frame playing, because that might, you as mom, you will know, like, is that really,
Yeah.
like, are they really happy, or like, you know, so that might be a good option too.
Good idea. Thank you.
Yeah.
All right. So I'm just going to really briefly touch on the role of the speech-language pathologist, because I heard that there's going to be some excellent session on augmentative communication tools and things like that. So, here we go, sorry. Although the majority of kids will have a delay or sometimes an absence of verbal speech, the research that we read really emphasizes that their receptive language skills are generally a lot more advanced. And speech-language pathologists, they really are the ones who have the expertise in things like alternative or augmentative communication devices. When they would do an evaluation, they would consider cognitive abilities, sensory impairments, and really determine the most appropriate form of communication. The AAC devices can range from super low tech, such as literally exchanging pictures to indicate what your wants and needs are, to really high tech voice generating devices. And there was a question that was a really good question about, like, if we're using these mobility devices, is it going to cause regression in your other skills? And the thing about the AAC devices that I read is they do not hinder verbal development, but rather they support optimal speech and language development. So that was a great question. Okay, so here is where my passion is going to come out. 27 years working in one place, Children's Minnesota, inpatients, outpatients, and then somehow I entered the world of children with congenital heart disease. But my biggest passion has always been about feeding and swallowing for kids. Any kids, all kids. And we know from working with people from all across the country that, excuse me, therapists who specialize in feeding and swallowing can be OTs, can be speech-language pathologists, and even one of my mentors was a physical therapist who worked out at Seattle Children's Hospital. So the things about feeding and swallowing can fall within different scopes of practice depending on where you live, what health system you use. It could be any of the disciplines. The most important thing to remember and ask is, you know, if they have the skills and they've done the advanced training to really treat the complex medical needs of kids with feeding and swallowing struggles. It can happen one-to-one, or feeding therapy can be through a multidisciplinary feeding clinic. One thing for sure is that feeding disorders stem from a multitude of issues, And feeding is an incredibly complex physiological process that involves the coordination of multiple body systems. And a disruption in any one of those body systems can lead to disordered feeding. And often for these kids, more than one body system is involved. And so given the complexity of what successful feeding looks like, anybody with a feeding disorder should really be managed accordingly with the input of multiple specialists. Areas that may contribute to feeding difficulty could include altered facial, dental, or even palatal anatomy. Even though the incidence is pretty low, some kids will have a cleft palate. There's research that shows that while your baby's birth weight might be pretty typical, their length might be within the normal range, we know that growth can be really challenging over time. I did read that there are specific growth charts for kids with Moat-Wilson that are available to track growth, which I'm assuming would be a huge win for families, especially if you are pushed to get your kids to grow. And I know that's something that happens in the congenital heart world all the time. Hypotonia early in life not only affects the development of things like sitting and walking, but it really can affect the muscles of the face and the tongue. We know that oral facial kind of hypotonia, and we see kind of an open mouth, it really can affect your ability to close your lips around a bottle nipple or the breast when you're an infant, or to use your lips appropriately on a cup as you grow. Chewing and things like that can be a struggle, and they can all lead to delays in things like advancing your diet, moving to solid foods, drinking from a cup, and all of those things can then lead to swallowing difficulty where potentially your foods or liquids might go down the wrong tube. One of the sources we used to gather information was the NIH gene reviews. It was pretty interesting. The one that we used was updated in 2019. And that reported that the incidence of Hirschsprung disease was about 44%. And then constipation, even without Hirschsprung's, was 29%. So we know that these kids really struggle with constipation. Chronic constipation typically can become more common as kids get older, but sometimes that can be due to factors such as insufficient liquid intake, low fiber diets, and so hopefully can be helped and managed a little bit that way, but we'll talk a little bit more about some specialty areas that can help too. Hirschsprung disease is a GI condition that's characterized by an absence of certain nerve cell bodies in the, whoops, not sure what I did there. There we go. In the muscle wall within a region of the large intestine. And as a result, there is an absence or an impairment of the rhythmic contractions that help move food through our digestive system. Symptoms then can be things like constipation, vomiting, poor appetite, and then really an accumulation of feces in the colon. Hirschsprung's can eventually change and lead to things like dehydration, diarrhea, and failure to thrive. With the many factors that can cause feeding difficulties, some children are going to require a feeding tube early in life. And I'm curious how many of you, your children, have needed any kind of a feeding tube? Okay, okay. Not great, but I'm happy to see that that hasn't been the case for everybody. I know for, again, with the kids that I focus and work with, there's a really high incidence of kids needing feeding tubes early in life because of their congenital heart disease. And several years ago, I met with a group of parents, and we're talking about feeding difficulties and challenges. And one of the things that I heard over and over again was, you guys, meaning the hospital systems, the medical system, put these feeding tubes in our kids, and then we leave the hospital and nobody owns the tube. Like nobody helps get rid of it. And so that really got in my heart. And so a small group of us did a massive lit search to look at how do you get kids off of feeding tubes? Because the cardiologist didn't want to own it. The primary physician was afraid of the cardiology piece, so they didn't want to own it. And then a lot of the GI doctors, all they cared about was maintaining the tube. And so it was pretty amazing what we learned. And really there are key ingredients for successful tube weaning. And they include the minute the tube goes in, you have a plan with your physician group, your therapy group, about, well, when is my kid going to be appropriate to get the tube out? And let's set goals. Because when it's medically needed, it's needed. But when it's not, sometimes kids get stuck on their tubes because nobody helps. The other really good key ingredients are making sure that you've got a multidisciplinary team, that families get education about how to provide positive mealtime and oral experiences. And then when the tube isn't medically necessary anymore, how to utilize a hunger induction weaning program to help them get off their feeding tube. So feeding therapy can look different for every kiddo, and it can be done in an outpatient clinic. It can be done through telehealth. I've had many dinners with families, which has been so cool. I'll be sitting there with my peanut butter sandwich and my Diet Coke, and there'll be, you know, brother Tim and sister Sadie and the child I'm working with and parents, and you get to see all the amazing, cool things that happen. And sometimes in-home therapies can happen that way too. All right, no notes. I'm gonna pull out my notes because I wonder if I gave you an older version of our, you don't have any either.
It's also this slide.
Oh, that could be it. Hey, there we go. Thank you.
And there's a question too, Nancy.
What's that?
There's a question too.
Oh, yes.
I have a question. Are there any resources that we can bring back to our therapists so that they can become more educated? Because I don't have any therapists who really have ever even heard of this condition. So it's really beneficial for them to learn more than I can provide to them.
Right.
So do we have anything in place I can refer them to?
I think one of the challenges, and we came across this in trying to prepare to really do a good job today, is there's not a lot out there. There's a lot on developmental delay and what we're going to talk about, the importance of early intervention and things like that. But when we looked for things specific to Mowat-Wilson, there's nothing.
Yes. So my therapists are great. They will look it up, but
Yeah.
We're their educators.
Right.
And
Right.
it's become like our speech therapist is like, oh no, she's fine. She's going to talk any day. And we're like, no,
Yeah.
you need to learn more.
Yeah. And that's so frustrating. And yeah.
There is a packet for like medical doctors and things that they have that might be useful to the other therapists, but it's certainly something to bring up as a way the foundation could also help us.
Yeah.
That would be super helpful.
My wife says important.
Oh,
I will bring that up too.
yes, that's.
Yeah.
that would
I
be
think we
good.
should do a collection of state-by-state resources.
Yeah.
Yeah.
And that's really similar to kind of where we were at in the cardiac world. There's a condition called hypoplastic left heart syndrome, and babies are born with basically half of a heart. It's rare. It's not as rare as Mowat-Wilson, but what happened was grassroots efforts from some providers that were champions and very much invested, and then families. And they came together and said, we need more, we need more, we need more. And then they slowly started pulling in other people from across the country, and now there's this amazing, beautiful national collaborative where, like with the tube weaning thing, we did that as a group of providers from across the country, really looking for solutions to the things that parents told us sucked and nobody was helping us with. And so what you have in this room right now is so much power to get some change, because you can come together and use your board and use your foundation to let them know what you need.
And along that lines, if we were to create some sort of a document, as therapists, what would it need for you to like trust it? Does that make sense? Does it just need that foundation mark and be like, hey, the foundation approved this? Because I could type up a little newsletter and be like, this is official, but it's not. I mean, does it have to have doctors behind it, research? What do you believe?
I would say everything I know about the importance of a multidisciplinary team. If you could have a physical therapist to talk about gait mobility, that is somebody who's been working with your children. I think you mentioned you've had the same physical therapist for years, seeing if somebody like that would be interested. If it's your feeding therapist, if it's your developmental pediatrician who you know is the guy who has seen a handful of children.
We have a medical advisory board.
Yeah. Yeah. Yep.
Our geneticist has happened to have seen several Mohawk kids do their property. Is this you or is this me? I thought that was me. It's you. Okay. And his Rolodex in his mind with therapists is huge. And he knows who to talk to. So, those people who are in that community, you can reach out to and just ask them, do you know the people local from the geneticist? And even talk to your other doctors. They know people.
And I'm also just thinking about the relationship that develops between the therapist and the family. Like, I think sometimes you have your people that are like, you're the parent, you know your child best, like tell me like what you're seeing and how I can help you. Like, I think finding a person like that too can be really helpful versus like somebody that's like, oh no, it's fine, like, who doesn't necessarily acknowledge, I don't necessarily know like how this is going to, how your child's gonna progress. Like, so I don't know, I think there's just something to be said about that therapeutic relationship that you have with your therapist too, and that it's okay if like it doesn't feel like a good fit, and if you need to move on from that relationship too.
Being an old fart, like I have learned the lesson over and over throughout my career. I may think I know stuff, and I may think I'm kind of hot stuff, but parents know their children the best.
Yeah.
And the minute I discount that, I'm not the right therapist for that child. And so making sure you're comfortable with your therapist and you can have those conversations. Like, I know you are saying that you're thinking they're gonna talk any day now. Here's the information I have. What are the things that lead you to think that? And just keep that communication going. I think in some of the systems, I think in some of the early intervention and school systems, I think that's tough because you don't have that hour face-to-face time with somebody in a room once a week. But keep trying.
Is there any sort of, there's like intensives for like
Yeah.
motor movement, gross motor
Yeah.
movement. Is there any sort of intensive type for speech specifically? My kid's only one, so I'm like
Yep. Yep.
hammering it in as
They
quick
don't
as
do much
possible.
for speech really before.
I know, and it's obnoxious.
Yeah.
My kid, I mean, earliest, my 5-year-old, he was saying words at one, he was walking by one,
Yeah, so was my first.
yeah, so I'm like, I know it's possible for kids. So the fact that they tell me that they want to push it out and wait later, I'm like, it's moving,
Yeah.
why can't I start more things now?
Yeah.
We did early intervention for our daughter we started at 7 months, and they wouldn't do anything before 2.
Right, which is why I'm like, there has to be more. Is there more, is the question. Yeah, you could. Well, exactly.
We also used to do advisory work on physical
Right.
therapy, have them reach out to their
Yeah.
therapists.
Yeah, we did starting at like 6 weeks with that stuff, like early intervention. And but I will tell you, we've lived in a few different states, and our son's only about to turn 4
And I'm going to talk about that a little bit. Yeah.
Majority of ours is out of pocket currently.
Yeah.
Which I'm fine fundraising for, I'm fine figuring out the ways to do it, I just need to know what it is that needs to be done.
Right.
Also,
Right.
you can get early intervention, get school therapy, and then get outpatient, like we did outpatient. Or we sourced
Yeah.
out
Like,
too.
he's been in therapy since he was 2 months old and
Good.
multiple different routes, but the speech therapy seems to be the hardest one for them. They're like, just get him cause and effect toys. I'm like, okay, he can slap the damn thing all day long, but I don't know what to do, you know, besides a little bit of repetition, but
Yeah.
he did a gross motor movement DMI intensive, and the change within that 10 days was insane.
Cool.
Like huge change.
Yeah.
So I'm just wondering if there's like a specific style of speech therapy.
I think that will be a really good question for the presentation tomorrow.
Yeah, and
That-
also PRC is here doing a workshop, they do, augmented AAC devices.
Yeah.
That'd be good for
Yeah.
Have you heard of NAPA?
That was
Yeah.
NAPA, I know that Mabel, I don't know if you know Mabel Boyer, but she went to the NAPA, and I know she did speech, but I'm not sure how young they start. But I looked into that too, and it's pricey.
It's
Yeah.
very pricey.
What
but-
do you guys have experience or opinions on that with, I mean, I know you don't have the Wilson experience, but with similar characteristics, have you found the NAPA programs to be? Because I know a lot from a lot of different, like, friends of mine that have kids in them. And like she mentioned, Mabel has done the one in San Diego,
Yeah,
but I have a
Cindy said
friend
it's
in
really
the Texas one, and they've had success with them, but how have you found?
Yeah, so so at Children's, we actually recently started using the universal exercise. I guess it's been 2 years now. So, I mean, kind of recent, but the universal exercise unit, which is the spider cage, which is what they use at NAPA, and we have our own intensive program. So there are other clinics like around the country that do have their own intensive therapy programs.
Right.
That might not just be NAPA, because I know that NAPA's great, but they're also like the place, and so there can be a really long wait list. Yeah, and I don't even know, do they take insurance? They do.
Oh, they take some, but I
okay.
know Mabel pays all out of pocket.
Okay.
Yeah.
It's like 3,000, I think Cindy said.
Yeah.
So like
And we'll-
all of, we'll talk. we're
We'll
gonna
talk a little bit more about
intensives too.
intensives, but definitely would be something to reach out to your medical community about
Yeah.
to find out more.
Yeah.
Definitely correct me if I'm wrong, but isn't crawling very much tied to speech development? So maybe sticking around.
There's a little bit of a recent controversy around that, in that crawling was removed from the CDC like milestones. I think as a therapist, like if I want my my patient to have the opportunity to crawl, but if they can move in other ways, then we work on that too, and it doesn't necessarily hold them back. So movement in general from progressing like in speech. So like movement in general, all of our speech therapists, I don't know if you've probably had similar conversations, but they're like, we got to get those kids moving, because when they have their big gross motor burst, then shortly after that is like when the speech explodes. So like I can't speak exactly to like if not crawling is going to affect speech, but I think if they can move, and if moving is different than crawling and they're still moving, I think that's going to continue to help them progress with their other developmental skills. And I don't necessarily harp on like we didn't get crawling done, but I still want them to try and have that similar experience.
Yes, so I kind of feel like an old fart too. But I'm kind of getting into the stage of like personal hygiene needs, and I'm just curious. My daughter goes to a specialized school where she has like a PT, OT, and those sorts of things, but they don't do speech, but they don't work on personal hygiene. Like, is that something that you need to get like as a private therapy to come into your home? Like, she's 8 and a half, so
Yeah.
just like really like showering and
I think it's
toileting and all that kind of stuff.
It's so frustrating, because I think somebody had mentioned it, and we'll talk about it too, but depending on where you live, like everybody has different rules. And that was something that like blew me away when I was trying to prep for this, because Minnesota, we're pretty good. You know, we follow all the federal recommendations. We follow all pieces of the IDEA. And when you look at the stuff in the Minnesota kind of guidelines, your school therapist can help with that, because being able to get in and use the toilet and be efficient and get you back in the classroom contributes to your academic success. But some will and some won't. And so if you're not getting what you need, when you ask your school people, then talk to your physician about, can we do some private? And sometimes you can get in-home services, but I know the companies that we have worked with have pretty strict guidelines for who can be served in-home versus where you would need to go to the clinic. I think one of our primary ones right now that we have loved referring to, because of the insurance and reimbursement and lots of stuff I don't understand, they can only have kids who are homebound, so like with a tracheostomy or something like that. So, but outpatient occupational therapy, finding clothing and adapting the fasteners to make it easier, you know, and then we'll talk a little bit in a minute about specialty programs to really help with the ball and bladder management and some of that. So, all right, this is going to be dry, but I do want to get through it because it really speaks to what we're talking about, and we're getting close on time.
Yeah, technically.
Yeah.
I mean, we have till, like, there's a break at 3:15, so if you want
Okay.
to over, as long as these guys don't mind, you know.
Okay.
I'm fine with that.
Well, I think we'll be okay. I think
we'll be speedy.
Basically, these slides are gonna tell what we've just been talking about, and we know that there's decades of research that show that a kid's earliest experiences really play a big role in brain development. The Center on the Developing Child at Harvard summarized a bunch of the research, and I'm not going to go into detail, but I think a couple of the key takeaways was like what Kelsey talked about neuroplasticity, and that our brains are so moldable and changeable, and it's really especially so in the first couple of years of life. Over time, it becomes more difficult to change. It can still change, but that early intervention is incredibly important.
What would you say that early age range would be?
What I read a few times was kind of up to age 3 is where you want to hit it hard. Do you have any more recent stuff that you?
No, I think I'm thinking like from a PET standpoint, sometimes we think about musculoskeletal maturation. So like, you know, like it might, a 6-year-old still, their skeleton is maturing
Changing.
and
Yep.
changing, and there's opportunities for remodeling. So like depending on the area too, I think it can vary.
And we know that there are things that you guys are dealing with. We read about the sleep regression that can happen. And things are going to change if my body is going through a sleep regression and the way my brain works and all of that. So it's not like you got until you're age 3 and then forget it. But what a lot of the research talks about is how important it is to start early, rather than what used to happen was, oh, let's wait and see. That's the thing that we have to throw out the window, because that's not true. I'm going to skip through some of this. I think one of the things too about early intervention is that high quality early intervention can really change your child's developmental trajectory and really improve long-term outcomes for the kids, families, and our communities. And we know that intervention is likely to be more effective and less costly when it's provided earlier rather than later in life. So early intervention services, they are designed to address the developmental needs of eligible infants and toddlers from ages birth to 3. And then this is where I was actually kind of confused because I'm used to the Minnesota way. I've been here my entire life. I've practiced here my entire life. But it's authorized by Part C of the IDEA, and it was created back in '86 to enhance development for infants and toddlers, to minimize costs to the educational system and society. But eligibility requirements vary from state to state. At a minimum, each state has to establish a rigorous definition of what the term developmental delay means, and then specifically how it's going to be measured. So like in Minnesota, early intervention is usually provided through the child's local school district, or for families who are homeschooling, it could be a special education co-op. And then they're coordinated through a program called Help Me Grow. They are free to anybody who is eligible, regardless of income or immigration status. I thought that was kind of cool. Services are typically provided in the family's home or wherever a child spends their time, so it could be at the daycare. And the core belief is that the family of the infant or toddler is central to the planning and service delivery, and they need to be involved in all goal development and priority setting. Preschool special ed services are also included in the IDEA, and then in Minnesota, the school districts provide free instructional and therapy services to eligible children in that intermediate, that age 3 to 5. So birth to 3 is a thing, and then we move into the schools for 3 to 5. When I was reading through this, I learned that states aren't even specifically required to participate in the Individuals with Disabilities Education Act. Although there's like something in the 14th Amendment that says that all states are required to provide children with disabilities a free and appropriate public education. And for the states that do choose to participate, they'll get federal funding and grants and things like that to help children from age 6 through 17. But they're not required to serve kids from birth to age 5 or from 18 to 21. And again, like I said, it just blew me away. I think we're real fortunate in the way that things are set up here. And that's always something, if you live in a state that is not providing your family with what you need, that would be an opportunity to talk to your legislators and as a community and a foundation to really see that if, that can be improved for you. Skip that. All right, so next we're going to talk about some of the specialty services that might be available outside of your typical OT, PT, and speech.
And I do believe it's 2:45, so if you would like to, we won't be offended if you step out. So,
yes.
We'll just keep going, and if you would like to step out, thank you for being here, and otherwise. Okay. So we talked about, there is Hirschsprung's disease and constipation, and so there are a lot of bowel difficulties that these children and that you are likely experiencing with your child. And so we actually have physical and occupational therapists that provide bowel and bladder rehabilitation services, and they treat constipation and Hirschsprung's disease. And then they can help with generalized bowel and urinary dysfunction, incontinence, or difficulty with toilet learning or toilet training. And these therapists treat patients from any age, all the way from young infants all the way through adulthood. And these therapists can provide services both in outpatient rehab and in inpatient rehab, in the hospital versus, versus clinic. And so again, they can really work on teaching bowel and bladder habits, strategies at different ages of childhood development, and then work on strengthening the pelvic floor muscles to help support going to the bathroom and to help control that bowel and bladder. Not many people are aware of the bowel and bladder rehab, and it's not really an area that is talked a lot about, but these therapists can really make a difference with these specific challenges. And I know that it can be quite, it's really distressing. It can be really distressing for kiddos and for families. So we have some really great therapists at our clinic that provide these services.
Is it me? Oh, sorry. I didn't put a whole lot more into this, but I think I talked a little bit earlier about there's also feeding clinics, multidisciplinary feeding clinics. So if your child has trouble with swallowing or advancing foods, or has a feeding tube, that's a nice opportunity to get the multidisciplinary approach. One of the things in literature that, even if a child has a naturally happy demeanor, they can still have depression and frustration and anxiety, and sometimes psychology can be a really good benefit, not just for our kids, but for us too. Some of the research that's happening in different fields right now shows that for infants with like congenital heart disease, developmental outcomes for that child are very much connected with maternal mom's mental health. And so taking care of you will impact your child. And it's so easy to forget that, but that's incredibly important. And sometimes that can be through psychology, but social work is also a huge help in different medical systems, and I think in the school systems too.
Seating clinics and wheelchair evaluations can be a service that can be helpful too. So some children are full-time wheelchair users and other children are maybe part-time wheelchair users, or it's just a tool that you have if your child gets tired easily and needs help when you're going to the zoo, and you want them to be able to still come with you, but they're too big for you to pick them up. Customized, or at seating clinics, it's usually PT or OT, and then an ATP, which is an assistive technology professional. And then they'll talk with you about your goals of seating, and then different features that may be helpful for your child for positioning, or ways that we can set up the chair that it will help them access stuff at school or at home. Another tool that we will often use is orthotics. And so we may recommend orthotics for a child who is having difficulty walking, if they fatigue easily, if they have increased tightness and we're trying to stretch and maintain range of motion, or if they have too much flexibility and then we need to help them protect their joints while moving. I do a lot of orthotics and a lot of walking and gait assessments, and I always tell my families that I'm looking at where their child is right now and what the goals are for their child right now, and we're gonna make a recommendation about their orthotic around that. And then after they grow out of these braces, you might have different goals, and they might be presenting differently, and so we might go with a different orthotic. So sometimes you might start with a certain orthotic, and then throughout their childhood and development, you end up with a different one. And then typically working with a physical therapist, an orthotist, and then a physician as well. Aquatic therapy, speech, OT, and PT can all be done in the pool if the facility offers it. The pool is great because it provides a really supportive environment, so kids are sometimes able to move in different ways that they can't when they're on land. So sometimes you'll put a kid in the pool and they'll just like start kicking and moving, and they're moving their body on their own, and they're so happy and excited about it, which is really cool. And then back to the intensity question, or intensive question. So we talked about intensity does matter when you're trying to make those neuroplastic brain changes. And so, like I said, at our clinic, we do have intensive therapy, and we have both PT using the spider cage, and then we have OT for CIMT, which is constraint-induced therapy, and bimanual therapy, so just really working on using both hands. And there is emerging research that is showing that intensive therapies are beneficial, and clinically what we've been seeing is like really huge gains. Like our kids they gain skills really quickly, and they carry it over, and those skills tend to continue after they've gone through their intensive. So a lot of our kids are transitioning from a weekly therapy model into like an intensive therapy model. So they do 2 intensives a year, 3 intensives a year, and then they don't have those weekly services, so that can free them up to do other things and do more vacations and fun family things and kid stuff. Hippotherapy, so therapeutic horseback riding, and it's usually therapy that is administered by PT, speech, and OT, so using a horse. Adaptive sports and inclusive activities are modified for children with different abilities so that they can participate. So I know Miracle League is, I think it's nationwide, but some of my kids do it locally and they love it. And so it's really cool, I think, for kids who just need a little bit more help to like still be able to do the things that peers are doing. Like they still enjoy it and like they get so excited about it. So just encouraging participation in adaptive sports or adaptive recreation can be really helpful and meaningful. Bikes can be adapted so that they have more supportive positioning and make pedaling easier, or so that they can be tandem and attached to a parent or adult bike. So I've written letters for families for grants so that they can get that adaptive bike equipment and go like bike around the lakes after dinner. And so adaptive bikes are another cool thing that can be helpful for kiddos. In Minnesota, different cities have adaptive recreation programs. So in St. Paul, there's actually, they have a calendar and they have various activities. So not only sports, but they have like crafts, bingo, dance night, group walks. They have all these other activities that provide opportunities for social interaction, which is pretty cool too. And I was thinking about like your 1-year-old. Like I think like, is there like a music group or something too, like where he can hear other kiddos sing and like that music? There's something about that music and that brain development. So
he's in daycare 2 days a week with like typical kids, so they do some music stuff during there. Mm-hmm. The boy lives with maracas in his hands.
Yeah, so like, yeah, just getting them involved in having those peer interactions can sometimes be underestimated, I think. So, all right, sorry, I forgot to move my slides here too. So I think ways to like help support your child, like letting your therapist know if you have 2 to 3 big goals that you want to accomplish for that burst of therapy, just letting them know what's important to you and what's important to your child. And then being part of that session. Like I like to pull parents into my session, or we have observation rooms at our clinic so parents can watch therapy, and then I can talk to them and say, I'm doing this for a specific way, and I am setting up this, like I'm putting this toy on this side on purpose because I want them to shift over there because I want them to transition that way. And so I think there's a big learning component for you all as well, and I know you guys are the experts in your kids, but if we can integrate you into therapy, I feel like it becomes more meaningful, and you're able to support your child at home so they can get that repeat practice in. And then you can tell us too, like, this isn't going to work at home. We need to think about something different, and that is helpful for us. And I want my families to ask me questions. I want to know, like, what do you need so that I can do the best that I can to help you. So I would just encourage you all to have as many conversations with your therapist as you can. Ask as many questions as you can. Don't ever think a question is dumb. And just, asking like, what can I do at home? Yes.
Getting back to the swimming,
Mm-hmm.
he's one, just turned one.
Yeah.
Can he just do a regular swim class?
I don't see why not. I think, as an infant, like you're gonna need to have that one-on-one family. I suppose I
Mommy
don't
and
know.
me.
Yeah.
Yep, or
yeah,
daddy and me.
Yeah.
Make it daddy because the water's cold sometimes.
Yeah. Like.
It
Yeah.
seems like he would just take off.
Yeah.
Yeah.
I would say like try it. Like see what.
Move.
Yeah.
Yeah.
Mhm. Yeah.
May I add something? I'm from Germany.
Oh, yeah.
My daughter is 8 years old, more representation, and we go to a swimming therapy once a year on an island in Spain.
Oh my
Wow.
gosh.
And they are doing swimming lessons or swimming therapy twice, 2 sessions per day, and then a session on land.
Cool.
And the founders, Paul and Chris, they have opened another spot here in the U.S. in Florida just last year or 2 years ago. And I can tell you it's amazing. Our
Cool.
daughter has made so much progress there. She has not only learned how to swim, but she has learned balance and stability. And it's hard work for the kids, intensity, as you said. But every time we go there, her self-esteem is raised,
Yeah.
and then she learns other things as well. You can see how it affects her cognitive abilities as well. It affects speech as well. So it's a very intensive but very beneficial therapy.
How long has she been doing this?
Since she was 4 years old.
Thank you.
Do you know
Thank
where
you.
Florida is?
I don't know.
What, do you know the name?
Yeah, Swim Lab International.
Swim Lab.
I think what we'll do, just because we did go over, we'll go ahead and wrap it up. But if you're still here and you're at other things and you want to come back, we're done at 4:30. We'll be hanging out for a little bit afterwards and happy to just problem solve and have conversations and all of that.
Yeah.
So,
yeah. Thank you.
thank
guys.
you.
Thanks for your discussion.